So I'm going to invite up Dr. Das to present our first speaker. Thank you.
It's my pleasure to introduce Dr. Hyun Kim. As our next speaker, Dr. Kim is an Associate Director and Senior Scientist at the Hinda and Arthur Magnus Institute for Aging Research at the Hebrew Senior Life, and Associate Professor of Medicine at Harvard Medical School and attending geriatrician at Beth Israel Deaconess Medical School. Thank you. Dr. Kim believes we can provide better healthcare to older people by incorporating Frailty into clinical care, research, and population health. Acting upon this belief, he founded the Frailty Research Program at the Marcus Institute for Aging Research. He developed a claims-based Frailty Index as a recent scholar and created the efrailty.org website, which hosts 15 different frailty assessment tools and web-based calculators to make frailty assessment accessible to both clinicians and researchers. As a result of his efforts, frailty assessment is increasingly being used for clinical decision-making and conversations about prognosis for patients and their family. Dr. Kim is a dedicated mentor, having mentored 40 early care researchers and has twice been recognized as a Mentor of the Year. His research has been funded by the NIA, Harvard Catalyst Medical Foundation, and the John A. Hartford Foundation. His academic contributions and recognitions include Associate Editor of the Journals of Gerontologic Medical Sciences, the 2017 American Geriatric Society Junior Investigation of the Year Award, 2023 American Geriatric Society, Thomas and Catherine Yoshikawa Outstanding Scientific Achievement for Clinical Investigation Award, and the election to the American Society for Clinical Investigation in 2024. He's published over 200 articles, and his research has been cited more than 12,000 times. Please join me in welcoming Dr. Hyun Kim.
Hey,
Get close to the mic, Evan. It doesn't.
this is good. Good morning, everyone. Thank you for the invitation and very generous introduction. Today, I'm going to talk about the frailty at the digital frontier, specifically how we move frailty as a clinical construct to something that can be measured reliably at scale and real-world setting. Here are my disclosures. So my role today is to frame the problem by defining frailty as a clinical measure of aging and vulnerability, and explaining why current frailty assessment failed to scale, and how AI and digital technology can help us reduce this gap and achieve scalable and valid frailty assessment. So I'm going to start with these three people who look very different, but who are connected by the same question. Mr. C is a 93-year-old man who was recently hospitalized for lower intestinal, gastrointestinal bleeding. And he was diagnosed with a sigmoid adenocarcinoma, and laparoscopic sigmoidectomy is under consideration. So he asked his primary care physician, would you recommend surgery? His age and diagnosis are clear, but risks and benefits are not. The fundamental question here is whether Mr. C has enough physiologic reserve to tolerate the surgery. The CEO of a large healthcare organization is looking at the data from the past year on the healthcare utilization and cost. And he learned that a small fraction of patients drive a disproportionate share of healthcare cost and service utilization. And this pattern is not explained by a single disease or a diagnosis. There are risk scores and cost prediction models, but he asked, how can we do better in identifying high cost and high risk patients that are not detected by existing models? Miss K is a 66-year-old woman with well-controlled chronic conditions. And she says, I feel fine, but how am I really doing? And how do I stay independent as long as possible? This question has no clinical answer today because we lack a routine ways to measure subtle changes in health before clinical symptom develops. All these three cases, they look different, but they share the same question. They're missing this information, the way to quantify physiologic reserve and resilience. So without this information, we make high-stake decisions late and allocate resources inefficiently and miss opportunity to support healthy aging. And frailty makes this vulnerability measurable and actionable. Let me now talk about the concept of frailty. This figure illustrates the progression of human development and aging over time. Our mental and physical capacity reaches their maximum in our early adulthood and decline afterwards. And we call this physical and mental capacity as intrinsic capacity, and frailty can be seen as a loss of that intrinsic capacity. The rate of decline in intrinsic capacity can vary among individuals. Some may not reach frailty until late in life, while others may reach frailty at relatively younger age. When a robust person experiences a minor illness like a urinary tract infection, they experience a small decline, and that is very short-lived. However, a frail person experiences the same minor illness. They experience a greater and prolonged decline. And they may not be able to recover the same level of function as their pre-illness baseline. The scientists who study the biology of aging, we call geroscientists, views frailty as the ultimate clinical expression of human aging. Among the hallmarks of aging, cellular senescence, mitochondrial dysfunction, deregulated nutrient sensing, and chronic low-grade inflammation seem to play an important role in altering physiologic systems. That changes include sarcopenia, change in hormone level, autonomic dysfunction, and decreased immune response to vaccines and natural infection. So clinically, people manifest low energy level, fatigue, low muscle strength, slow gait, physical inactivity, and unexplained weight loss. In other words, symptoms of frailty. So once frailty develops, the vulnerability becomes visible. So we see this in outcomes like falls, delirium and cognitive impairment, functional decline, disability, and medical and surgical complications in our clinical setting. And all these pathways converge on the outcomes that matter most to the patients and families and healthcare system: death, nursing home placement, healthcare utilization, and cost. In a 10-year follow-up study, a frailty measured at the beginning of their older adulthood at age 66 was able to predict mortality and multiple chronic conditions, including dementia and disability over the next 10 years. And we also found that people with frailty acquire these age-related conditions at a faster rate than those without frailty at age 66. And frailty is a continuum from being fit to pre-frailty to frailty and end-stage frailty. And where a person lies on this spectrum really shapes how we provide clinical care to the patients. For a person who's fit or pre-frail, often the goal of the treatment is to increase physiologic reserve and maintain independence through exercise, nutritional supplementation, chronic disease management, and preventive care. But as the frailty progresses, the clinical focus shifts to reducing stressors and minimizing harms through relaxing chronic disease management target, stopping medications that are potentially harmful and of questionable benefit, reducing home hazard, and providing support and comfort-focused care. So the key point here is that frailty assessment tells us not just who's at risk, but also how we can tailor our clinical care to each stage. So now I'm going to talk about the conceptual models of frailty. So to summarize the concept, frailty represents decline in physiologic reserve and intrinsic capacity. And as reserve goes down, people lose robustness and resiliency in response to a stressor. And it is ultimate clinical expression of biological aging. And importantly, it is a spectrum, not a binary state of frail versus non-frail. So frailty is not rare, and it's not limited to a single care setting. In the community, 1 in 8 older adults is frail, but that number goes to 1 in 2 patients in the hospital or nursing homes. Given the prevalence of frailty and its clinical significance, recently the CMS approved that frailty screening should be part of the age-friendly hospital quality metric starting in 2025. At the same time, the Lancet Commission on Frailty was formed to reorient frailty as a central construct to guide clinical practice, public health, and policies for aging population. So now I'm going to introduce 2 dominant theories of frailty. So the first theory is called frailty phenotype, proposed by Dr. Linda Fried. And the next one is deficit accumulation frailty, proposed by Dr. Ken Rockwood and his colleagues. Frailty phenotype defines frailty as a clinical syndrome that arises from altered energy metabolism and abnormal stress response. And it is measured based on the presence of the following features: weight loss, exhaustion, physical inactivity, slow gait speed, and weak grip strength. And having 3 or more features is considered having frailty. In comparison, deficit accumulation frailty sees frailty as a state of poor general health that results from accumulation of age-related health deficits. So here, what I mean by deficit can include symptoms or diseases, functional status change, laboratory abnormalities that can occur more frequently with age. Deficit accumulation frailty is quantified using frailty index, or FI. And FI is the proportion of abnormalities in a standardized clinical examination. So when you're conducting a comprehensive assessment that includes 50 items to a patient, and that person has 20 items wrong, the person's frailty index is 20 divided by 50, or 0.4. That corresponds to the moderate level of frailty. Typically, 0.25 or higher is considered frail. Because this is a proportion, it can range theoretically from 0 to 1. But 99% of the population has a score below 0.7 or 0.8. So in the clinic, when you're seeing a patient whose frailty score is 0.7 or 0.8, you're seeing a person who is top 1% of the frailty distribution in the population. So this assessment is an example of deficit accumulation frailty index operationalized using the items we collect routinely in comprehensive geriatric assessment, or CGA. So we call this assessment CGA-based frailty index, which includes items in medical history, self-reported functional status, cognitive and physical performance test, and nutritional status. Once you complete this assessment, you get this radar plot, which shows the impairment across different domains of health for the patient. And you can use this information to target your intervention and provide individualized care. So this particular patient has high level of impairment in muscle strength and a moderate level of impairment in IADL, instrumental activities daily living. So you can prescribe physical therapy and exercise intervention to address muscle strength, and you can make sure that patient has enough social support to do instrumental activities of daily living. In addition to this graph, you get this population reference data to see how your patient scores compares to the population norms by age and sex. So the patient score is noted in the red line, and the two solid lines represent the population mean for men and women, and then the dashed line on the top is 99 percentile values for men and women. So let's say this person is an 80-year-old woman, and so this person is a frailty index is greater than the average of the age and sex matched peers, and that level is close to somebody who's 5 years older. So this information can be helpful to discuss prognosis with the patients and make clinical decisions before stressful treatment. So how is frailty really assessed in clinical practice? There are a number of tools that have been developed and validated for clinical use. But some tools are variants of frailty phenotype, some tools are variants of deficit accumulation frailty, and there are frailty tools that are designed, optimized to predict the poor clinical outcomes in a specific population like surgical patients or cancer patients. But when you talk about frailty, you have to recognize that all the tools are not measuring the same thing. So of the 15 tools that I showed in the previous slides, mobility and balance domain and medical comorbidity appear in many tools, followed by nutrition, muscle strength, cognition, and functional status. So depending on the tools that you're choosing, you may be measuring a different aspect of vulnerability for the patient. So this creates a problem of comparison and implementation and interpretation of the results. So how do we choose a frailty tool in clinical practice? The key question here is, what is the purpose of the assessment? So generally speaking, simple assessment, the brief tools, often self-reported assessment, is good for rapid screening. But by design, this tool does not provide a detailed information necessary to provide care plan. In comparison, comprehensive assessment, like CGA-based frailty index, provides information across different health domains, which is necessary to provide an individualized care plan and targeted interventions. So once you have chosen your frailty tool, then the next question is it really possible to scale this? In reality, the uptake of frailty assessment in clinical practice has been very slow for many reasons. First, there are many tools with no consensus definition. So this makes clinical adoption confusing and inconsistent. The time and resources are limited, especially for those comprehensive assessments. Our current health system is disease-based rather than whole person-based. Recall that frailty reflects how the whole person responds to a stressful event. there is no standardized workflow for how and when frailty is measured, by whom, and how the results should be used. And lastly, for many clinicians, frailty does not have a good clinical utility. In other words, they're not sure what to do differently once frailty is assessed. To address some of these challenges, we developed this eFrailty website, which hosts 15 different validated clinical frailty tools and their web calculators. This is to help disseminate validated frailty assessment for clinicians and researchers. And one of the features of this tool is this crosswalk between different frailty tools. So each bar represents a different frailty assessment tool, and then the scores in the red part of the column represents frailty, and the blue part of the column represents non-frailty. And the y-axis indicates the frailty index according to the deficit accumulation frailty, which ranges from 0 to 1. So let's say a frailty score according to deficit accumulation frailty 0.25 corresponds to 1 point in the frail scale and 1 point in frailty phenotype, and then stage 5 in the clinical frailty scale, and so forth. So this crosswalk helps you translate a score from one tool to another tool, allowing comparison between different time points and different also clinicians. To scale the frailty assessment to the population level, our group and many others developed claims-based frailty index, which predicts a person's frailty level based on administrative claims data. So this claim-based frailty index is used widely for research, but its accuracy is not as good as clinical frailty assessment, and is not available in real time at the point of care. And it can be affected by access to care, health-seeking behaviors, and coding practices of healthcare providers. So now I have reviewed two strategies to scale frailty assessment: eFrailty to help disseminate validated frailty tools and standardize interpretation among different tools, and claim-based frailty index to scale the frailty assessment to the population level, but with limited clinical utility. So the next step is, well, if we use AI and digital technology, how can we improve our ability to measure frailty? So we have this clinical frailty assessment tool, but because of the limitation that we just reviewed, there is a growing interest in using EHR-based method to assess frailty, to make it available at the point of care for a lot of patients, and also extend frailty assessment beyond the clinical setting to allow continuous monitoring of frailty level in real-world living environment using sensors. AI and technology can be useful for measuring and extracting frailty-relevant signals from health data and standardizing raw data into something that is clinically interpretable and meaningful to clinicians, and integrating multidimensional signals to quantify and characterize vulnerability. One approach that has been used in the literature is to train an AI model using clinical frailty assessment as a reference standard to come up with a frailty score or classification of frail versus non-frail based on diagnosis code, clinical notes, radiology, vital signs, and lab tests. But this approach predicts a frailty as a single global construct, and it looks like a black box. It has limited interpretability, but it can be useful identifying who's frail and who's not frail. Another approach is to train multiple AI models for the components and the domains of frailty. And once you train different AI models for each component of frailty, you can use that output and aggregate them according to a predefined clinical rule or using another AI model to generate the overall frailty score. So this approach predicts frailty components explicitly, therefore giving better interpretability. And it may be helpful for guiding targeted intervention according to that domain-specific impairment. So what becomes possible with AI and technology? Well, they enable early detection of vulnerability before clinical frailty develops. And they allow frailty assessment at scale beyond the clinical setting. They make it possible to monitor trajectories of frailty longitudinally rather than a one-time snapshot. And lastly, we have opportunity to evaluate treatment response to various interventions and frailty interventions. So each modality comes with a unique strength, but also with some caveats. In EHR-based assessment, the clinical frailty assessment label that reference standard frailty is not widely available, making model training more challenging and difficult. EHR data has miscoding and systematic bias that reflects how we document and how we deliver care rather than true vulnerability of the patients. Currently, rich unstructured notes and imaging data are underutilized, and a model developed in one system may not generalize to a different health system. Sensor-based assessment can include wearable sensors as well as ambient sensors, and they allow continuous monitoring. But what is the optimal device and placement and metrics are not clear yet, and there's also need for shared standards in data processing. And adherence and usability are crucial if you intend to monitor frailty longitudinally, because they only exist as long as people are willing to use them over time. A third modality that is worth mentioning is patient-facing AI chatbot. From a workflow standpoint, this is a way to collect frailty-related information before the clinic visit. And it's good at structured information capture using user-friendly conversational interface. But its accuracy depends on cognitive function, sensory function, and digital literacy of users, and which can be a problem for many older adults. As a result, equity and accessibility to this technology is an important consideration. So far, I have reviewed what frailty is and why it matters, and how we assess it clinically, and how AI and technology can potentially scale this assessment. So I want to close my session by stepping back asking this question. So where is frailty assessment headed next? Currently, frailty assessments are episodic and clinic-based, and they detect vulnerability after it has already occurred clinically, and then provide a static snapshot of one's health. But in the future, we want frailty assessment to be continuous and extend beyond the clinical setting to the real world. And it allows early detection before clinical symptoms develop, and help us understand the dynamic trajectories of frailty, like how people respond to different types of stressful events. So I'm going to give 3 take-home points. First, frailty is a clinical measure of aging-related vulnerability, reflecting diminished physiologic reserve and resilience. Second, clinical frailty assessments are useful, but do not scale beyond episodic and clinic-based care. and AI and technology have the potential to enable scalable, earlier, and longitudinal frailty assessment. And validation and integration remain the frontier. Thank you.
Okay, we've got time for a couple of questions if you want to remain at the mic. I think we're looking for a question, Mike. So for now, yeah, David.
We have one question online from Charlotte Yi. So the question from Charlotte Yi online, she has a sort of one and a follow-up is, since we know emotional well-being and emotional resilience, not just physical resilience, also contribute to aging and well-being, sense of purpose, social connection, and positive view of aging, she mentions Becky Levy's work, shouldn't they be included in frailty measurement? And then sort of a follow-up is that how do frailty assessments take into account disabilities that may not be linked to frailty, such as mobility issues, prosthetic legs, arms, et cetera, or grip weakness because of prior hand surgeries or trauma?
Well, thanks for the question. I do agree that emotional health is an important component of maintaining independent life. So it should be included in the frailty assessment. And some of the tools do include mood or depression as part of the assessment. But as I mentioned earlier, that different tools measuring different aspects of vulnerability. So some tools include, an item on depression or mood, but other tools don't. So I think that's something to consider when you're choosing a frailty tool. And then there are, to answer the second question, there are health problems that we acquire may not be directly related to aging. So obviously, this frailty assessment, which captures the deficits that are associated with aging, is a rough guidance. And obviously, we have to individualize the interpretation of frailty score. We should use it as a guidance rather than a deterministic score that because your score is this, then you are able to or not able to receive a particular treatment. So I think that's a consideration. But in general, a lot of physical disability problems, mobility problems, a lot of those problems occur with part of the aging. And that's why they're included in the frailty index calculation. But if there's somebody who has an accident and prosthetic, limb, which may not be related to aging per se, so I think that has to be taken individually, exceptionally. Thank you.
You take a couple of questions from the room, but I'll just ask you to repeat the questions. I'm not sure if we'll pick up on that. So who has a question?
Yes.
Please. Yes, go ahead.
Great. Dave, fantastic work. I'm wondering if you can comment on how we can leverage AI to also help teach those users of whatever tools they're using. So if they're leveraging the CGAFI, how could we then maybe use everything else that's in the electronic health record to help guide both clinicians and patients for what to do next? Sort of the next frontier of what actually help improve it.
So the question is, how can we utilize AI to teach users how to use information from frailty assessment? I think that's an excellent comment, and that's should be the future of our frailty work. That a lot, as I mentioned, many clinicians outside of geriatrics and aging feel that frailty is a risk assessment tool, but how to apply that to clinical management is not obvious to many clinicians. So I think we can use AI to guide them or nudge them to the right direction of the care, so that have you considered these possible interventions based on the frailty profile of your patient? And so that could be something that we can consider. So that could be part of an EHR nudge or some order set based on the profile of the patient's frailty assessment. So that's an excellent comment.
Thank you, Dave, for the talk. So my question is, when you think about moving from a one-time assessment to continuous, one of the things that happens is of the 50 things that you could collect online, maybe 12 of them or 10 of them can be collected easily on a daily basis, right? Not everything can be captured at the same granularity. So is there a sense in the community about which of them might matter the most, or if there's a way do you feel like that list can be whittled down to a shorter, more continuously monitored, perhaps, index that may be different from the one that you're able to do today with the Frailty index, which is all of it?
Yeah, I think clinically, frailty is a dynamic state, but we don't think the frailty changes like today and tomorrow. So it's a latent a state that changes over time gradually, rather than day-to-day variation. So sometimes that measuring that level of variability can be informative to assessing somebody's frailty level, but I think some of the mobility measures, activity volume measures can be tracked more frequently than some of the other measures that we assess every year or every 6 months. So I think if we can decide on what measures are feasible to measure at higher frequency and informative to assessing this person's level of frailty, I think that's that can change over time in the future. But I think currently some of these like sleep patterns and activity patterns, mobility, these are more frequently measured metrics that could be incorporated in the frailty. But I don't think the frailty can reflect today and tomorrow the difference. But it's more of a pattern, overall pattern over the past certain period. But we don't know how long that period should be. So that's part of the question that we need to answer.
I think we should move on with the program. We'll have lots of time for questions in the panel discussion, but just to keep us on track, especially with folks joining online, we'll leave that here for this session. We'll invite Dr. Nuss to come up again for the next introduction. Let's thank Dr. Kim again. Thank you.